The immune system is your body's defense system. It is what fights off bacteria, viruses, and anything else trying to make you sick. But here's the thing, the immune system is not some separate organ in your body, it is a group of cells doing the work. And those cells have a name you already know, white blood cells. If you watch video one, then you know they are the one of three main cells in your blood. Red blood cells carry oxygen, platelets stop bleeding, white blood cells fight infection. White blood cells are the immune system. They are the soldiers. They are the security guards. They are the ones doing the actual work of keeping you from getting sick. So when you hear the words immune system anywhere in this video, I want you to picture white blood cells, just cells in your blood doing their job. Now, here's what I need you to know about white blood cells before we go any further. They are not all the same. There are several different types of white blood cells, and each one has a different specialty. Some are first responders, they show up fast when there's trouble and start fighting right away. Others are specialists, they take longer to get to the scene, but they bring specific skills. Some learn the enemy and remember it so they can attack faster next time. You do not have to memorize every type, but you do need to know that white blood cells are a team. Different members of the team do different jobs, and together they keep you protected. So, in this video, we are going to walk through those three things: how the team actually works, what happens when something goes wrong with it, and HIV and AIDS, which is one of the most tested topics in your unit. You need to understand this because almost every patient you take care of will have something going on with their immune system. The elderly patient whose white cells are weaker with age, the cancer patient whose chemo wiped out their white blood cells, the patient on steroids that suppresses their white blood cells, the patient with allergies whose white cells overreact, the patients with HIV whose white blood cells are being destroyed by the virus. Every shift, every patient, you will be thinking about this, whether you realize it or not. How the immune system actually works. The immune system has two teams, like I mentioned before, um, both made of white blood cells, both working together to keep you safe. Um, Let me introduce them really quick. Team one, the first responders, the first team that shows up fast. They do not wait. They do not study the enemy. They just see something foreign and attack. Here's what they look like in action. You slice your finger chopping vegetables. Bacteria from the knife start starts to trying to get into the cut. Within seconds, the first responders show up. Your blood vessels open up, pour more of them in the area. They start attacking the bacteria right away. They literally eat them, they surround the bacteria, swallow them, and digest them. This is why your cut get red, warm, and swollen. That is not your finger being broken or anything like that. That is your first responders pouring into the area to fight. All right. First responders are fast. They attack anything that does not belong. They cause the redness and swelling you see when your body is fighting an infection. Team two, the specialists. The second team is different. They are slow. They take days to get into the fight. But once they do, they bring something the first responders cannot. They learn the enemy, they study it. They make weapons designed specifically for that one specific germ. And here is the amazing part, they remember it forever. Here's what that looks like in action. You catch a cold, the first responders show up right away and start fighting. That is why you feel awful for the first day or two. But the cold virus is sneaky and the first responders cannot fully kill it on their own. So your body calls in the specialist. The specialists go to work studying the virus. After a few days, they start making weapons called antibodies. An antibody is a tiny protein your body builds to attack one specific germ. Think of it like a lock and key. Each antibody is designed to fit perfectly onto one specific virus or bacteria attached to it and mark it for destruction. Your specialist makes millions of antibodies, all customized for the cold virus that is making you sick. The antibodies find the virus, they attach to it, they mark it. The first responders see the marked virus and finish it off. The cold goes away. That took about a week. That is why colds last about a week. The specialists needed time to make the weapons. But here's the part I really want you to focus on. The specialists do not forget. After the infection is over, some specialist cells stay alive in your body. They remember the cold virus, they keep the antibody design ready. So if you ever get exposed to that same exact virus again, the specialists jump into action hours instead of days. They already know the enemy, they make antibodies fast. You fight it off before you ever feel sick. That is also how vaccines work. A vaccine shows your specialist a weakened version of a germ so they can study it and remember it. Now, if you ever met the real disease, your specialists are ready before you even know you have been exposed. Lock this in. Specialists are slow but specific. They make antibodies designed for one specific germ. They remember the enemy. That is how immunity works. And that is how vaccines work. How do two teams work together? So your immune system is just two teams working together. The first responders hold the line while the specialists get ready. The specialists finish the fight and remember the enemy. The next time the same germ shows up, the specialists are ready to fight right away. That is a healthy immune system, both teams working together. Most days you can never most days you never even knows that this is happening. Now keep this in your head as we go forward. Every disease we are going to talk about in this video is going to be a problem with one of these two teams. Sometimes both. The teams are missing or they are weak or they are attacking the wrong thing. If you understand the first responders and the specialists, you are going to understand the diseases. Let me show you what happens when something goes wrong. Okay, so what happens when the immune system is too weak to fight? Let's talk about Aisha. Meet Aisha. Aisha is a 34 year old. She had a kidney transplant 2 years ago. Before that, she was on dialysis for 6 years, watching her life shrink as her kidneys failed. The transplant gave her life back. She's married. She has a 4 year old daughter, works as a teacher, and feels healthy most days. But there is a catch. For the rest of her life, Aisha has to take medication that suppresses her immune system. Why? Because the kidneys inside her body is not her own. It came from a donor. And her immune system is, if left alone, will see that kidney as foreign and attack it. The medication tells her immune system to stand down, to not attack the kidney. But it does not just stand down from the kidney. The medication suppresses her entire immune system, both teams, the first responders and the specialists. Everyone is told to relax. So Aisha can keep her kidney. The trade off is that her body cannot fight off germs the way it used to. This morning, Aisha is in the hospital, not because anything is seriously wrong yet. She came in because she developed a low fever and a cough that is not getting better. In a healthy person, that would be a cold. For Aisha, even a small infection can spiral into something life threatening. So her doctor wanted her admitted to be watched closely. You are her nurse today, and I want to walk you through what your job looks like. This is what's going on inside Aisha's body. Our white blood cells are still there, both teams, first responder, specialists, but the medication is holding them back. They cannot do their job at full strength. So when bacteria or viruses enter her body, the response is slow and weak. Things that her immune system would have crushed 2 years ago can now take over. Aisha is what we call immunocompromised. Big word, simple meaning. Her immune system is compromised, not working at full power, which makes her vulnerable. Now, Aisha is not the only kind of patient who fits this picture. Let me show you a few others so you can recognize them when you see them. Marcus. The 6-year-old with leukemia we talked about in video 1. His chemo is wiping out his white blood cells. He is severely immunocompromised. There's also Miss Hopkins. She's 82, lives alone, came in with pneumonia. Her immune system is not damaged by disease or medication. It is just naturally slower because she is older. The first responders move slower. The specialists make fewer antibodies. So pneumonia in an 82-year-old is a much bigger deal than pneumonia in a 30-year-old. Then there is Mr. Riley. He is on prednisone for 10 years for severe asthma. The steroid keeps his asthma under control, but it also dampens his immune system every single day. He gets sick more easily than most people his age. And then there is Daniel. He has HIV. We are going to talk about him in depth later in the video. His specialist team is being attacked by a virus. His immune system is breaking down piece by piece. 5 different patients, different reasons, same problem. The immune system cannot defend them the way a healthy person would. And that means you are their defense until their immune system can do its job. You are doing it for them. So, how do we protect Aisha? Let me walk you through what her care looks like. Because every single thing we do is built around one idea, keeping germs away from her. First, Aisha is in a private room. She's not sharing with another patient. The other patient might be carrying germs Aisha cannot fight. Private room only. Second, look at her room. There are no flowers. There are no plants. Her family wanted to bring her a bouquet from the gift shop. She had to say no. Why? Because the soil in a plant pot and the water in a vase grows bacteria. Most people would never notice that. Aisha could get a serious infection from just having those in her room. Third, look at her meal tray. There is no salad, no fresh fruit. Her food is fully cooked. Even her fruit comes peeled and cooked, like baked apples instead of a fresh apple. Raw produce can carry bacteria that her body cannot fight, so her food is prepared differently than what other patients get. Fourth, look at her visitor list. Her husband and daughter can visit, but only if they are well. Her sister called this morning saying she was coming, but she has a cold. You told her sister she cannot come in today. Not today. Wait until you are better. That is part of your job. Protecting Aisha, sometimes telling her family no. Fifth, every single person who comes through that door washes their hands first. You, the doctor, the nursing assistant, housekeeping, her husband, there are no exceptions to this rule. Aisha's life depends on it. Six, you watch her like a hawk for fever. Her temperature is being checked more often than other patients. In a healthy patient, a low grade fever is uncomfortable. In Aisha, a low grade fever can be the first sign that something is spiraling. If her temperature goes up even a little, you do not wait. You do not finish charting and come back. You go tell the RN right away. That is the picture of caring for an immunocompromised patient. Every detail is built around one thing, protecting her from infection because she cannot fully protect herself. Now, I have a name for everything we just walked through. It's called neutropenic precautions. You're going to hear this term a lot in your career. Neutropenic just means low neutrophils, which are a specific type of first responders, aka white blood cells. When the first responders are low, we put the patient on precaution. Aisha qualifies because of her medication. Marcus qualifies because of his chemo. Anyone whose immune system is significantly compromised qualifies. The precautions are the same no matter why the patient is immunocompromised. Different cause still means the same protection. Now, what do you teach Aisha when she goes home? Most of the time, the same rules apply, just in her own life. She washes her hands constantly before she eats, before she touches her face, after she touches anything in public. She avoids sick people, even close family. If our daughter brings home a cold from preschool, she takes extra precaution, mask, distance. Sometimes one of the grandparents takes the daughter for a few days until she is better. She avoids crowds during cold and flu season. No big indoor gatherings, no crowded grocery stores. She shops at off hours. So she goes to the store when it's typically not crowded. She cooks her food well, no raw fish, no undercooked meat, no soft cheeses, no buffets. She gets her vaccines on schedule, but only the ones that are safe for someone on her medication. Some live vaccines are off limits. Her transplant team tells her which one she can have. She knows what to call about: any fever, any new cough, any new wound that looks red or warm, any rash, any new symptoms that feels off. She does not want to wait. In the part no one really talks about, being immunocompromised for life is exhausting. Aisha is 34. Her daughter wants to go to birthday parties. Her husband wants to take her on vacation. Her friends wants to meet up at restaurant. Every social decision becomes a calculation. Is the risk worth it? Will she be safe? Is this the day she catches something? That weight wears on a person. Be a nurse who acknowledges that, who does not just hand her a list of rules, who treats her like a young woman trying to live her life, not just an infection risk in bed 14. So that is Aisha. That is what an immunocompromised patient looks like, why her body cannot defend itself, and how you protect her until her immune system can take over again. Okay, so we just talked about when the immune system is weak. Now let's talk about when the immune system goes overboard. So Aisha's immune system was too weak. Now I'm going to show you the opposite problem. When the immune system can also work too hard, it can attack things that should be harmless: pollen, peanuts, bee stings, penicillin. Sometimes the reaction is annoying: sneezing, itchy eyes, a rash. And sometimes the reaction is so severe it can kill a patient in minutes. Let me show you what I mean by that. Let's meet Olivia. Olivia is 24 years old. She just graduated from college. Today, she's at a friend's wedding reception. She's sitting at a table with people she does not really know. Someone brings out a plate of appetizers and sets it in the middle of the table: stuffed mushrooms, mini quiche, little pastries. Olivia grabs a pastry, eats it. About 30 seconds later, her mouth feels weird, tingly. Her lips start to feel funny. A minute later, she is rubbing her throat. It feels tight, like there is something stuck in it. She tries to swallow, and it does not feel right. 2 minutes later, she is wheezing. She cannot get a good breath. Her face is getting red, puffy. Hives are breaking out across her arms and her chest. She tries to ask the person next to her for help, but her voice sounds strange and thick. Her friends look at her. Olivia, what is wrong? Olivia points at her throat. She cannot really talk anymore. Her friends dig frantically through Olivia's purse and finds an EpiPen. She stabs it into Olivia's thigh. Then she calls 911. So what just happened? Olivia just had an anaphylaxis. And if her friend had not had the EpiPen, Olivia might not have made it to the hospital alive. Let me walk you through what was happening inside her body. Years ago, Olivia ate a peanut as a child. Her body did something that does not happen in most people. Her immune system saw the peanut as a threat. The specialists studied it. They built antibodies designed to attack peanut protein. From that day forward, every time Olivia ate a peanut, those antibodies were ready. The pastries at the wedding had peanut flour in it. She did not know that. The second she ate it, her antibodies recognized the peanut. They sounded the alarm. Her immune system launched a massive full body attack against the peanut. The attack is what almost killed her. Here is what was happening. Her body released a chemical called histamine, massive amounts of it, all over her body at once. Histamine is what causes the symptoms of an allergic reaction. And in anaphylaxis, the histamine flood does three dangerous things at the same time. It made her Airway swelled shut. That is why her throat felt tight, why her voice sounded thick, why she started wheezing. Her body was literally closing her own airway. It opened up her blood vessels so wide that her blood pressure was about to crash. If the EpiPen had not gone in when it did, she would have gone into shock within minutes. Her organs would have stopped getting blood flow. And it made her skin react. The hives across her arms and chest, the swelling in her lips and face, that puffy red look, all in about 3 minutes. That is what anaphylaxis looks like. Throat closing, blood pressure dropping, skin breaking out in hives, face and lips swelling, all at the same time. So, if you ever see a patient with two of those things happening together, sudden highs plus trouble breathing, sudden swelling plus a blood pressure drop, this is anaphylaxis until it is proven otherwise. Do not wait. Now, I want you to know the most common things that causes this: peanuts and other nuts, shellfish, bee stings, penicillins, and other antibiotics, latex. Those are the ones that cause the most anaphylactic death. You will hear about other allergens too, but those are the heavy hitters. If a patient has a known allergy to any of those, your awareness goes up. So, what's the treatment? There is one drug that saves the patient, epinephrine, we just talked about. It's the only first line treatment for anaphylaxis. Nothing else will reverse it. Not Benadryl, not steroids, not oxygen. Those things help, but epinephrine is what saves the life. Epi works by reversing everything anaphylaxis is doing. It tightens the blood vessel so the blood pressure can come back up. It opens the airway so the patient can breathe. It calms the immune response down. It is given as a shot in the muscle of the thigh. That is what the EpiPen does. In the hospital, the team has other ways to give it, but the medication is the same. After Epi, the team also gives Benadryl, steroids, oxygen, and IV fluids. But epinephrine goes first. Um, and I want you to understand that anaphylaxis can come back even after has been given. The patient might look fine, and then an hour later, the symptoms hit again, sometimes hours later. So, a patient with anaphylaxis is admitted for observation. Even if they look great after one dose, they stay until the team is sure it is not coming back. Now, picture this: you are working, you walk into a patient's room, the patient just got a new IV antibiotic about 10 minutes ago. You walk in and they are scratching their arms, hives. You look at their face, their lips look bigger than they did this morning. They tell you their throat feels weird. What do? In this moment, I want to walk you through it. Like, envision yourself actually at the bedside in this scenario. You call for help, yell, hit the call button, get the RN in the room. You stop the IV antibiotics. The medication is causing the reaction. Stop it. You stay with the patient. You do not leave to go find help. Help comes to you. The RN gets there fast. Epi goes in. You assist with everything they need: vital signs, oxygen, fluids. You position the patient. If they are having trouble breathing, sit them up. If their blood pressure is dropping, lay them flat with their legs up. And that's kind of like an old school way to bring blood pressure up. So you want to stay up to date with current research on if that is appropriate. You watch their vitals constantly: blood pressure, heart rate, oxygen saturation, because anaphylaxis can drop a patient's vital signs fast. You document everything for the team: what you saw, when you saw it, what you did, what time epi went in, what time everything else happened. This is the action sequence. It happens fast, it happens with the team, but you are the one who initiated it because you walked in the room and recognized that something was wrong. Now, what do you teach Olivia before she goes home? Once you get everything back to normal and she's stable, Eventually, she's going to be discharged. So, what do you tell her as part of discharge teaching to reinforce learning? The single most important thing she would ever do uh, for her life from now on is carry her EpiPen always. Two of them, one on her persons, um, and if she has a, so she's going to carry two of them on her persons. Okay, she doesn't want to leave it in the car or at home. She wants them on her. She has to read every food label every single time, even food she has eaten before. Manufacturers change ingredients without big announcements. One missed label could kill her. She has to tell every restaurant about her allergy, every server, every kitchen. Cross contamination kills people every year. She needs a medical alert bracelet. If she has a severe reaction in public and cannot speak, first responders need to know what her allergy is the moment they go get her. Okay? That's what's most important, and the details matter. So, this is the second way that the immune system failed. First, it worked too hard. It attacks things that should be harmless. The worst version of it is anaphylaxis, which can kill a patient in minutes. And we just need to recognize the pattern, give epi, and watch the patient closely just to make sure that the symptoms don't reoccur, come back. All right. What happens when the immune system attacks the body? All right. So now I want to show you the strangest way the immune system fails. In autoimmune disease, the immune system attacks the body itself, the patient's own joints, their skin, their thyroid, their kidneys. The immune system gets confused and starts treating pieces of the patient like germs that need to be destroyed. Now, let me say that again because I know that can be a little confusing. The immune system attacks the patient's own body on purpose day after day for the rest of their life. So, to understand what that actually looks like, I want you to meet Rosa. Rosa is a 38-year-old. She's a mama too. She works as a hairstylist. About 3 years ago, she started noticing her hands hurt in the morning, stiff, achy, hard to make a fist. She thought it was just from cutting hair all day. Then it got worse. Both hands, then her wrists, then her knees. The mornings were the worst. It would take her almost an hour just enough to loosen up enough to get her kids ready for school. By noon, she felt a little better. By bedtime, she could barely lift her arms over her head. She went to the doctor. Blood work showed inflammation all over her body. More tests showed her immune system was specifically attacking the joints in her own hands, her wrists, her knees. She was diagnosed with rheumatoid arthritis, an autoimmune disease. Let me show you what is actually happening inside of Rosa's body because once you see it, every autoimmune disease is going to make sense. Remember the last two teams of the immune system, first responder specialist, both teams in Rosa are healthy and working. But somewhere along the way, the specialists got confused. They looked at the tissue inside Rosa's joints and decided it was foreign. They built antibodies that target her own joint tissue. So every day, those antibodies are attacking her joint. The first responders see the antibodies attached to her joints and pile in to finish the job. The result is constant inflammation inside her joints, pain, stiffness, swelling, damage that builds up over the years. She did not catch anything. She did not eat anything wrong. She did not do anything to cause this. Her own immune system just turned on her. And now it is destroying parts of her body it should be protecting. That is autoimmune disease. Now, Rosa has one specific autoimmune disease, but autoimmune disease can attack almost any part of the body. Same problem, different target. I'm going to show you one or more autoimmune diseases in depth because it shows up on tests a lot. Meet Andrea. Andrea is 26 years old. She's a graduate. She's in graduate school. She has been feeling exhausted for months, but figured it was just stress from school. Then she started getting joint pain in her hands and knees. Then she got a rash on her face. The rash started on her cheeks and then spread across the bridge of her nose. It almost looked like a butterfly with its wings open. Her doctor took one look at the rash and ordered specific blood work. The results came back showing lupus. Lupus is another autoimmune disease, but here is what makes it different from rheumatoid arthritis. In Rosa, the immune system mostly attacks the joints. In Andrea, the immune system attacks many different parts of the body: the skin, the joints, the kidneys, the heart, the brain. Different patients with lupus have different symptoms because the immune system might be attacking different things in the patient. Doctors sometimes call lupus the great pretender because it can mimic so many other diseases. One patient might come in with kidney problems, another with joint pain, another with a rash, but all of them have lupus. The classic lupus patient is a young woman, often black, Hispanic, or Asian. Lupus is way more common in women than men. It often shows up between the teen years and the 40s. The butterfly rash on the face is the most famous sign of lupus. If you see the pattern in a young woman with joint pain and a fatigue, lupus should be on your radar. Lupus symptoms often come and go in waves called flares. During the flare, the disease gets worse. New symptoms, more pain, more damage between flares. The patient might feel pretty good when they're not having flare ups. So, treatment is partly about preventing flares and partly about controlling them when they happen. So, if we want to briefly mention other autoimmune diseases, you have multiple sclerosis, type 1 diabetes, Hashimoto's and Graves' disease, celiac disease. Those are all forms of different autoimmune diseases. So, how do doctors diagnose autoimmune diseases? Blood work mostly. They look for signs of inflammation in the body, which shows up as elevated lab values. They look for specific antibodies that show up in specific autoimmune diseases. Um, and they use that to guide treatment. So, how do you treat autoimmune disease? So, we cannot make the immune system stop attacking. We don't know how to do that yet. So instead, we tell the immune system to back off. We use medication to suppress it. The main category of medication is steroids, like prednisone. Steroids are powerful at calming the immune system down. They reduce the inflammation. They can control the system symptoms. The trade-off is that suppressing the immune system means the patient and fight cannot fight infection as well. Remember Mr. Riley from the immunodeficiency section? He was on long-term prednisone for asthma. Same trade-off. Autoimmune patients on long-term steroids are essentially immunocompromised. They are protecting themselves from their own immune system, but the side effect is they are now vulnerable to outside germs. There are also newer medications called biologics. These target specific parts of the immune response, very effective but expensive. And they also suppress the immune system. So, now, what is your job at the bedside? Well, okay, three things matter the most. First, pain management. Many autoimmune patients are in real pain: joints, muscles, fatigues, headaches. Treat their pain seriously, believe them when they tell you they hurt. Second, watch for flares, new rashes, more pain, new symptoms. new fatigue. These mean the disease is getting worse. Report flares to the team because the patient might need a medication change. Third, watch for infection. These patients are immunocompromised because of their medication. Same precautions we used for Aisha earlier. Hand hygiene, watch for fever, protect them from sick people. A small infection in an autoimmune patient on prednisone can become a big deal fast. So now, what are you going to teach Rosa and Andrea? Take their medication exactly as prescribed. Never stop steroids suddenly. You never stop steroids suddenly. Steroids have to be tapered off. Stopping cold can cause a serious medical crisis. Avoid infections, and we talked about that already. Know what flares look like and call a provider when symptoms get worse. For the lupus patients, you want to avoid sun exposure. UV light triggers lupus flares. Um, so these are the patients that should have wide brim hats, sunscreen, and long sleeves. For rheumatoid arthritis patients, specifically protect their joints, avoid heavy lifting, use ergonomic tools, take rest breaks. In the emotional piece, living with it, autoimmune disease is exhausting. The disease never goes away. Be a nurse who acknowledges this is hard. All right, so that is autoimmune disease. Um, the next section we're going to talk about is HIV and AIDS. Okay, HIV and AIDS. This is the most important section of this whole video. HIV and AIDS shows up on every nursing exam you take. Um, the syllabus calls them out specifically, and these are diseases you will see in real patients in your career. Some of them living with HIV for decades, some newly diagnosed and scared. So we need to get this right. I'm going to walk you through the entire disease, one patient, start to finish. So let me introduce you to Marcus. All right. Marcus is 29. He works in graphic design. He has been with his partner for 4 years. He plays in a softball league on Sundays. He goes to the gym mostly mornings before work. About 6 months ago, he started feeling tired, tired in a way that did not match his usual life. He thought maybe he was overworking. Then he developed a fever and night sweats that lasted about a week. He noticed his neck felt swollen, like his glands were enlarged. It felt like a really bad flu. He went to the doctor. The doctor ran a panel of tests. One of those tests came back positive. Marcus has HIV. Let me walk you through what is happening to him. HIV stands for human immunodeficiency virus. So it's a virus. Just like the flu is a virus, just like a cold is a virus. But HIV is different from those because of what it attacks. Remember the CD4 cells we talked about back in part one? I told you they were generals of the immune system. They do not fight infections themselves, they organize the fight. They tell the other white blood cells what to do. But there's one thing I need to add for clarity. CD4 cells are actually a type of cell called a T cell. Your textbook is going to use both terms. T cells are one of the major types of white blood cells in your specialist team. There are different kinds of T cells. CD4 T cells are the generals, the ones that organize the immune response. They are also CD8 T cells that act more like soldiers, attacking infected cells directly. So when you hear T cells, just know that is a category. When you hear CD4 specifically, that is the general. HIV targets the CD4 T cells. All right. So if you need to play that section back, make sure you understand what's going on. CD4 is a particular T cell. The virus gets into a CD4 cell. uses the cell's own machinery to make copies of itself, and then destroys the cell on its way out. Then those new copies of HIV go find more CD4 cells and destroy those over and over. So while Marcus is going on about his life, HIV is slowly killing his generals. For the first few months after infection, Marcus might not know he has it. His body fights back, his CD4 uh, count drops a little, but stays in a workable range. He feels fine, sometimes for years, but the whole time, HIV is multiplying in his body, attacking CD4 cells faster than his body can replace them. Eventually, his CD4 counts drop low enough that his immune system cannot defend him anymore. The other white cells are still there, but they do not have any leadership. The whole army falls apart. When his CD4 count drops below 200, or when he develops certain infection that only happen in people with very weak immune system, this disease has progressed from HIV to AIDS. AIDS stands for acquired immunodeficiency syndrome. It is what happens when HIV has been destroying CD4 cells long enough that the immune system has failed. So, HIV and AIDS are not two different diseases, they are two stages of the same disease. HIV is the virus, AIDS is what happens when the virus has been doing its work long enough to destroy the immune system. All right? HIV is a virus, AIDS is the advanced stage of the disease. CD4 T cells are the target. Below 200, CD4 means AIDS. How HIV is spread. This is the most important part of this section because the misinformation about how HIV is spread has hurt patients for decades. So let me be clear with you. HIV is spread through certain body fluids: blood, semen, vaginal fluids, rectal fluids, breast milk. Those are the fluids that carry enough virus to pass it from one person to another. So, how does HIV actually get transmitted? Sexual contact, any kind of sexual activity where one of those fluids gets into another partner's body. Vaginal sex, anal sex, less commonly oral sex. Sharing needles. People who inject drugs and share needles can pass HIV directly through blood. A tiny amount of blood left in a used needle can carry the virus. Mother to baby. A mother with HIV can pass it to her baby during pregnancy, during birth, or through breastfeeding. With proper treatment during pregnancy, the risk drops to almost zero. Healthcare exposure. A needle stick injury where a nurse gets stuck with a contaminated needle. Blood transfusions. Used to be a rare risk, but blood is now screened so well. It used to be a risk, but blood is now screened so well in the United States that it is extremely rare. Now, let me tell you how it does not spread because this is just as important. HIV does not spread through saliva, so kissing is safe. HIV does not spread through sweat, so sharing a gym towel is safe. HIV does not spread through tears, through casual contact. Shaking hands is safe, hugging is safe, sharing a meal is safe. It is not spread through dishes or silverware. Viruses die quickly outside the body. It is not spread through toilet seats, mosquitoes, or other insects. It's not spread by being in the same room as someone who has it. The reason why I am being so specific is because patients with HIV have been treated badly for decades because of myths about how the virus spreads. Family members who refuse to share glass, co-workers who pull away, even healthcare workers who put on extra protection when they do not need to. All of that hurts the patient. None of it protects anymore. You can shake hands with Marcus. You can give him a hug. You can sit next to him at lunch. You can share a bathroom with him at the hospital. None of those things will give you HIV. What will transmit HIV in healthcare is contact with his body or body, with his blood or body fluids without proper protection. Which brings us to standard precautions. With standard precautions, you do not put on extra protection just because a patient has HIV. You put on protection based on what you are doing, not who you are doing it for. This is called standard precautions. The idea is that we treat every patient like they might have something bloodborne, not just patients we know are positive, every patient. Because a lot of patients with HIV, hepatitis B, hepatitis C, and other diseases do not even know that they have it yet. So when you are doing something that involves potential exposure to blood or body fluids, you protect yourself the same way for everyone. Gloves when you might touch blood or body fluids, gown when fluids might splash on you, mask and eye protection if there is a splash risk to your face. When you are just talking to Marcus, taking his vital signs or giving him oral medication, you do not need any special protection. You wash your hands before and after, like with any other patient. The reason this matters is because you protect you from the patients you do not know are positive, and it protects the patient with HIV from being treated like a leaper. When we use the same precautions for everyone, the patient is positive. When we use the same precautions for everyone, the patient who is positive does not feel singled out. Standard precautions show up on every nursing test you will take. So make sure you understand this. Prevention. For someone who is HIV negative, the goal is to stay that way. Safe sex with condoms reduces risk significantly. People who inject drugs should never share needles. Many cities have programs that provide clean needles. There's also a medication called PrEP, pre-exposure prophylaxis. People who are HIV negative but at a higher risk can take this medication daily, and it dramatically reduces their chance of getting infected if exposed. There is also PEP, post exposure prophylaxis. If someone is exposed to HIV, like a healthcare worker who had a needle stick, they can start a medication within 72 hours of exposure to prevent infection. The sooner the better. For pregnant women with HIV, taking medication during pregnancy reduces the risk of passing HIV to the baby to almost zero. For Marcus, prevention now means protecting his partner. We will go into that in a minute. Okay, prevention. For someone who is HIV, no, we talked about that. Okay, diagnosis. How did Marcus get diagnosed in the first place? A blood test, or a couple of blood tests, actually. The way HIV testing works has two steps. First, the patient gets a screening test. That is a quick test that looks for HIV antibodies or HIV antigens in the blood. If the screening test comes back negative, the patient is considered HIV negative. So we're done. But if the screening test comes back positive, the result has to be confirmed with the second test before the patient is officially diagnosed. Why? Because a screening test can sometimes give a false positive. So we double check. The classic confirmation test is called the Western blot. Western blot is more detailed blood test that confirms whether the antibodies in the patient's blood are actually HIV antibodies. Newer labs use different confirmation tests now, but Western blot is the name you will see your textbook in on your exam. So we're going to focus on that. There are also rapid tests now that give results in about 20 minutes. These are used in clinics, in emergency rooms, and even at home. A positive rapid still needs confirmation with a more detailed test. Now, this is important. HIV is one of the only blood tests where the patient has to give specific consent before you draw it. You cannot just run an HIV test on a patient because you think they should have it. Different states have slightly different rules, but in most places, the patient has to give either written consent or documented verbal consent before the test is ordered. Why does HIV testing require special consent? Because of the history. HIV has been used against people in the past. People have lost jobs, lost insurance, lost custody of their kids, been treated badly in healthcare. The consent requirement exists to protect patients from being tested and labeled without knowledge. So if you ever hear a doctor or nurse say they need consent for an HIV test, that is why. The patient has to know what is being done and agree to it. After the test confirms HIV, the patient gets follow up labs. They check the CD4 count to see how strong the immune system is, because remember we discussed if the CD4 count is lower than 200, HIV has progressed to AIDS. They check the viral load, which measures how much virus is in the blood. That guides treatment. Marcus was diagnosed early. His CD4 count is 480. His viral load was high but treatable. He has HIV, not AIDS. With proper treatment, his viral load can drop to undetectable levels and he can live a life. He can live a long, full life. Okay, treatment. HIV is not the death sentence it was 30 or 40 years ago. Treatment has come so far. The main treatment is called antiretroviral therapy, or ART. The patient takes a combination of medication, usually once a day, that blocks the virus from making copies of itself. That is not a cure. The virus is still in the body, but the medication keeps it suppressed so it cannot destroy more CD4 cells. When a patient takes their ART consistently, their viral load can drop to undetectable. That means the virus is in their body, but at such low levels that lab tests cannot detect it. Here's the part that changes everything. Studies have proven that people with HIV who live in undetectable viral load cannot transmit HIV to their sexual partners. This is called undetectable equals untransmittable, or U equals U. It is a real scientifically proven fact. Marcus is going to start ART. Within a few months, his viral load can become undetectable. He can keep being with his partner. They can have a normal sex life with appropriate precautions. He can live a normal life span. Patients on ART have to take their medications every single day for the rest of their life. If they stop, the virus comes back and starts destroying CD4 cells again. So this is lifelong treatment. The medication used to have a lot of side effects. The newer ones are much better. Most patients tolerate them well. Okay, so now we need to discuss what happens when HIV progresses to AIDS. If a patient does not get treatment, or if treatment fails, the virus keeps destroying CD4 cells. Eventually, the CD4 count drops below 200. At that point, the patient has AIDS. A patient with AIDS is severely immunocompromised. They start getting infections that healthy people never get. We call these opportunistic infections. They happen because the immune system is too weak to fight them off. Common opportunistic infections include certain types of pneumonia, tuberculosis, severe yeast infections in the mouth and esophagus, and a rare skin cancer called Kaposki's sarcoma, and many others. A patient with AIDS often presents with one of these infections, which is what tells the doctor that the disease has progressed. With modern treatment, even patients with AIDS can sometimes recover their immune system enough to push back into the HIV category. This is the disease is not always linear, but it is much harder to recover from AIDS than to prevent it in the first place. That's why early diagnosis and consistent treatment matter so much. HIPAA and privacy. This is a huge section. It's very important. So let's make sure you truly understand um, the privacy that HIV and AIDS patients um, must receive. This is very important. HIV status is medical information. It is private. It is protected. You do not share it with anyone who does not need to know. Marcus's co-workers do not need to know his HIV status. His parents do not need to know unless he wants them to. Other patients at the hospital do not need to know. People in the waiting room do not need to know. His employer does not need to know. The only people who gets to know are the healthcare team directly caring for him. And his immediate household and sexual partners need to know because they are at risk. But that is not your call to make. That is at his decision to share with them, often with help from a counselor. If you talk about Marcus to anyone outside the team caring for him, you are violating HIPAA. You can lose your license, you can be sued. The hospital can be sued, and you have hurt and you have hurt your patient in a way that can take years to repair. The same goes for casual conversations with coworkers about patients in general. Even saying I had this HIV patient last week in a break room where other people can hear is a violation. You do not discuss patients identifiably in places where others can overhear. So you need to be mindful of being at the bedside when family members or friends are there, and you need to call out medications or have certain discussions because you don't know if whoever's visiting knows why he's there. So you need to be very cautious of the information you discuss in front of other people, especially dealing with HIV and AIDS. Even if you know that their partner is unaware, it is not your call to make to inform them. All right. Stigma with HIV and AIDS patient has carried for more than decades than any other disease in modern medicine. Decades of misinformation, fear, and prejudice. Even today, patients with HIV often hide their diagnosis from family and friends because they are afraid of how they will be treated. You are going to meet patients who have not told their parents, patients who have not told their best friend, who hide their medication bottles when guests come over. You might also meet patients who internalize the stigma, who feel shame about their diagnosis, um, who do not feel they deserve love or happiness. None of that is true. HIV is a virus. It does not say anything about who Marcus is as a person. It does not change his worth. He does not change whether he deserves respect and care. When you take care of an HIV patient, you treat them like any other patient. Same warmth, same eye contact, same gentle touch, same explanation, same dignity. Do not put on extra gloves when they are not needed. Do not pull back from touching them. Do not whisper about their diagnosis at the nurse's station. Do not act like they are dangerous when they are not. Be a nurse who makes them feel safe. Sometimes you might be the first medical professional who has ever made them feel that way. Your job at the bedside is to care for them and their disease. Remember to use standard precaution, normal interactions, and education about taking medication consistently and offer and give support. For the patients with a low CD4 count or active AIDS, you're caring for someone who is immunocompromised. So remember how to protect them. Remember to educate them on taking their medications every day. Never stop, never skip. Practice safe sex. Stay on top of their vaccines if they are eligible. And take care of their mental health. HIV is a lot to carry. Counseling helps. So to pull it all together, HIV and AIDS are the same virus. AIDS is just the advanced disease of HIV that has been attacking the body for too long. All right, so now we need to talk about blood types, and then we're going to blood transfusions, and that should wrap up the immune system. Now, there are four main blood types: A, B, AB, and O. Your immune system has a bouncer. The bouncer's job is to check every red blood cell that comes into your body and decides whether it belongs. The bouncer learned at birth which blood it is supposed to recognize. That is your blood type. Anything else that comes in, the bouncer attacks. I'm going to walk you through each blood type one at a one on one at a time. And we are going to start with the simplest one and build up from there. Type O. If you are type O, your blood is plain. That means nothing on it, no markers, no special anything, just a plain red blood cell. Your bouncer was trained from birth to be suspicious because your blood has nothing on it. The bouncer learned that anything extra is a stranger. That bouncer will attack you. When you receive O blood, bouncer is happy. Plain blood, just like yours. When you receive A blood, bouncer sees something extra, so it's going to attack. So what I'm saying is, if you were born and your blood type is O, you can only receive O because it matches and it's plain. But if someone with A blood donates to you, when that A blood hits your bloodstream, your bouncers are going to say, "Whoa, whoa, whoa! Wait a minute. This is not plain. This red blood cell is marked with A. I don't recognize you." So it's going to attack because you don't belong here. Only plain O blood belongs here. If B blood enters the bloodstream, that means that those red blood cells have a B on it. And so the bouncer is going to attack them as well. If AB enters the bloodstream, it's going to attack that as well because A and B blood is two sets put together, and you can't split them up. So they're going to be attacked as well. So type O can only receive O blood. Anything else, the body is going to attack. Now, here's the cool part. Because O blood is plain with nothing on it, O blood can be given to any patient. No bouncer in the world will attack plain blood. There's nothing for the bouncer to react to. A patient with any other blood type receives O. The bouncer looks at it and shrugs, nothing to attack, let it in. That is why O is called the universal donor. O blood can go into anyone, but O patients themselves can only receive O. Lock this in. O is a universal donor, meaning it can be given to anyone because it's plain. But O can only receive O because if I try to give you A, B, or AB, they're not plain. They have a mark on them, so they can't enter the body. Now, type A. Type A blood we're going to, for the sake of this lecture, whatever blood type it is, that's going to be the mark on the red blood cell, right? So if a person has type A blood, the red blood cell, each red blood cell is going to have an A on it. So when I say mark with A, I'm just saying that each red blood cell has A on it to help us distinguish between red blood cells because we're learning. All right. When someone gives you A blood, so I have type A blood and I need a blood transfusion, and they found someone with type A blood to give me blood to replace my blood. When they start the IV and give me that type A blood, my bouncers are going to say, "Okay, I recognize you. You can come in." When someone gives me O blood, my bouncer's going to say, "Okay, you can come in," because those red blood cells are plain. They don't have a mark on them, so there's nothing to attack. The bouncer is going to treat that O blood like they belong because they don't have anything on them, so they can come in. So type A can receive type A blood, and then they can receive O blood because it's plain. Now, what happens if I'm type A and I get type B blood? My body's going to stop you at the door and attack because you don't belong here. Your red blood cells are titled B, and I don't recognize that. So my um, bouncers are going to be ready to fight to get you out. Now, AB, don't let AB uh, trip you up because if I have type A, you give me AB, don't think that changes anything because you see the A. What happens is with A, B, you can't separate them. You can't split them up. A comes with B. So even if the bouncer recognizes A, it's still attached to B. So it's going to attack it because you can't split them up. So AB blood cannot be donated to A. So A can only receive A and O. Everybody can receive O. Okay, the same with type B. If a B patient, type B patient needs B blood, they can only receive type B blood or O. They can't get AB because the B is attached to the A and we can't split them up. So they're going to get B or O. Now, type AB. Don't get confused. Let me walk you through slowly. With AB, they can get A because A is paired by itself and A is compatible. So the AB recognizes type A red blood cells so they can come in. AB can receive B because they recognize the B red blood cells. AB can definitely receive AB, and then AB can also receive O because it's plain. So AB can receive blood from all of the groups. But, well, there's really no but. So AB is the universal recipient because it can receive blood from anyone. O is the universal donor because it can give blood to anyone because it's plain. Right? Got it. Now, with blood groups, we also have RH factor that we need to talk about. People are either RH positive or they are RH negative. So it's the same concept as the blood bouncer, either attack or let you in. RH positive patients have the RH marker on their red blood cell. Their bouncer recognize it. They can receive RH positive blood. They can also receive RH negative blood because RH negative is plain, nothing to attack. RH negative patients do not have the RH marker. Their bouncers have never seen it, So if you give them Rh positive blood, the bouncer sees the Rh marker and attacks it. Rh negative patients can only receive negative blood. All right, so not only do we have blood types, we have Rh positive and Rh negative. Rh negative is plain. Rh positive has a marker, so think of a plus sign. So if a positive red blood cell, Rh positive blood cell hit the bloodstream, that positive mark is going to signal to the bouncers, do you belong here or not? If Rh negative hits the bloodstream, it won't because it's not marked, it's plain. It can go in. So when you put it all together with the blood types A, B, AB, O, the safest emergency blood in the world is O negative, right? Because O by itself is plain, and then negative by itself is plain. So when you're deciding to give blood, it's not just the type of blood that needs to be compatible. You need to know the RH status, negative or positive. So O is plain and negative is plain. And to be sure in an emergency, if you don't have the blood type, O negative is the best to give since it's compatible with all blood types. All right, we made it to the end. So let's briefly talk about blood transfusions from start to finish, and that should end our immune system lecture. All right, why do we give blood? Patients need transfusions because something they need has run out or been lost. They are running on empty in one specific area, and we are refilling the tank. If they are bleeding heavily or severely anemic, they need more red blood cells. We give packed red blood cells, just the red blood cells, not the whole blood. If their platelets are dangerously low and they are bleeding, we give platelets, just the platelets. If their clotting factors are used up, like in DNC, DIC, or major trauma, we give fresh frozen plasma. Plasma is the liquid part of blood that contains the clotting factors. If they need specific clotting proteins like fibrinogen, we give cryoprecipitate. Each one replaces something specific. Whole blood with everything in it is almost never given anymore. We give the part the patient needs and leave the rest for someone else. Packed red blood cells for anemia, platelets for low platelets, plasma for low clotting factors. Okay, because each one has a specific job. Now, before the transfusion, um, there's certain things you just have to do. The provider orders the transfusion, maybe based on the low hemoglobin, maybe because the patient is actively bleeding, maybe because their platelets are critically low. The patient has to give consent for the transfusion, not just verbal, okay consent, written, informed consent. The provider must explain the risks and benefits. The patient signs, and the consent goes in the chart. Now, the lab work. The lab does not. The lab does a type and screen first. This is two things at once. The type the patient's blood. They type the patient's blood, which means they figure out the patient's ABO blood type and Rh factor that we just discussed, and they screen the patient's blood for any unusual antibodies that can cause a reaction. Sometimes patients have weird antibodies in their blood from previous transfusions or pregnancies. and the lab needs to know. Some patients only need a type-in screen on file, which is enough to tell the team what kind of blood the patient could safely receive if they needed it. But before any actual unit of blood is given to a patient, the lab also needs a cross match. The cross match is when they take a specific unit of donor blood and physically mix a little of it with the patient's blood in a test tube to make sure they do not react. If they do not react, that specific unit is safe for that specific patient. Type in screen for the workup, cross match for the actual unit. Once the cross match is done and the unit is ready, the blood lives in a blood bank. This is a separate department in the hospital where they store and test blood products. The blood bank is usually refrigerated. When the unit of blood is ready for your patient, you the nurse go down to the blood bank to get it, or hospitals have it delivered. Either way, the blood has been formally checked out in the blood bank from the blood bank for that specific patient. And once you have the unit, the clock starts. You have to hang that blood within 30 minutes of removing it from the blood bank refrigerator. If it sits at room temperature for too long, it has to go back or be discarded. Why? Because once blood warms up, bacteria can grow in it. So you do not pick up the unit, go take a break, and come back. You pick it up and you hang it. You also need to know this. Once the transfusion is started, the bag has to be completely infused within 4 hours. That is the rule. If you have not finished the bag within 4 hours from when it was left, from when it left the blood bank, the rest of it has to be discarded. Bacteria can grow even in a bag that is already running. So a unit cannot just hang there slowly all day. You start it, you watch it, and you finish it within the window. 30 minutes from blood bank to hang, 4 hours to complete the transfusion. Now, before any blood goes in the patient, two nurses verify everything together. Two nurses side by side going through the unit together. This is called um, the nurse check. And it is the single most important safety step in the whole procedure. You check the unit together. You verify the patient name and date of birth, and match the patient's wristband to the blood tag. You make sure you have the right product, packed red blood cells, platelets, whatever was ordered, blood type, and RH. It must match the unit. Um, you look at the right unit number. Every unit has a unique number. Match it to the order. Expiration date. Make sure the blood is not expired. Visual inspection. Look at the bag. Make sure nothing is leaking. No clumps. No weird color. Both nurses sign off. Both check together. No must and make sure everything is fine. Now, it doesn't, you also want to take the time to look at the order. So when a nurse comes to you and say, hey, can you check this unit of blood with me? I had to start a transfusion. Just take a moment and look at the order for yourself and verify that what's being given was order. And you want to look at the order yourself because you're just as responsible as the person signing, um, as the nurse coming to get you because you're signing your name and witnessing that everything is correct. Okay, setting up the line. Blood is not given through regular IV tubing. There's a special blood tubing with the filter. The filter catches any clots or debris in the donor blood before they reach the patient. You also need normal saline to prime the line. Normal saline is the only IV fluid that is compatible with blood product. Even though lactated ringers is isotonic, ringers has calcium that can clot in the blood in the tubing. Blood tubing usually has a wide connection with two spikes, one going into the saline bag, the other going into the bag of blood. So you can prime the line with saline first, then switch to the running blood. The patients need a good IV, usually at 18 or 20. Bigger gauge needles let the blood flow well. If the IV is too small or clotted, the transfusion will not run right. You also want to take baseline vital signs before you start. temperature, blood pressure, pulse, respiration, pulse ox. Document them because if something changes during the transfusion, you need to know what normal look like. So if your patient starts off with a fever or anything abnormal, you need to communicate that with the doctor. And sometimes they will give treatment before the blood transfusion, and you just want to document that. All right, starting the transfusion. You hang the blood, you connect the tube in, you start it slow, usually about 20 to 50 milliliters per hour for the first 15 minutes or whatever the hospital policy is. And you need to stay with the patient for the first 15 minutes, okay, to make sure the patient will not experience allergic reaction. And if they do, you want to be there to intervene quickly. After the first 15 minutes, if they are doing well, you can speed up the transfusion to the normal rate. You can also step out, but you check on them often. Vital signs are typically taken at 15 minutes, then 30 minutes, then hourly. Each unit of red blood cells usually takes 2 to 4 hours to infuse. Remember, the 4 hour rule cannot exceed 4 hours total. Platelets are faster, maybe 30 to 60 minutes. Watch for reactions. If your patient starts having itching, hives, a rash, wheezing, or trouble breathing, or facial swelling, you need to stop that transfusion. Mild allergic reactions are common and usually treated with an antihistamine like Benadryl. Sometimes the transfusion is paused, sometimes restarted at a lower rate. Severe allergic reaction can progress to anaphylaxis. Same thing we talked about earlier. And this will require epi and an emergency response. If your patient starts having a allergic reaction, stop the infusion and get your RN. Reassess vitals, and then the team decides whether the reaction is mild enough to manage and restart or severe enough to stop entirely. Now, there are different types of reactions the patient can have. They can have a febrile reaction. This is where the patient develops a fever during the transfusion, usually with chills. The patient's immune system is reacting to white blood cells or proteins in the donor's blood. It's not as dangerous as hemolytic reaction, but it still feels awful for the patient. What you see is a fever, usually 100.4 or higher, chills, shaking, headache. The patient feels miserable. Okay. And like we said before, you stop the transfusion, notify the RN, and then you have to reassess. All right. Hemolytic reaction. This one can kill. What is happening? The patient got blood that does not match their blood type. Maybe a clerical error, maybe a mischeck. The patient's bouncer attacks the donor red cells. Massive destruction of the donor blood. The destroyed cells flood the patient's system. Kidneys try to filter the mess and can fail. Blood pressure crashes. What you see usually starts within the first 15 minutes, which is why you stay with the patient. Fever and chills, low back pain, flank pain. The kidneys are getting hit really bad. Dark urine, sometimes red or brown from destroyed cells. Anxiety, drop in blood pressure, difficulty breathing, chest tightness or pain. If you see any of the signs, you stop the transfusion immediately. Uh, Recheck vital signs. You disconnect the tubing from the patient. You leave the IV in place. You start normal saline running through a new set of tubing through the IV. You call the RN and the provider. You save the blood bag and the tubing. The lab needs to figure out what went wrong. You monitor vital signs continuously. You document everything in real time. A hemolytic reaction is a medical emergency. The patient may need IV fluids, medication, oxygen, sometimes ICU level care. The faster you stop the transfusion, the better the outcome. This is why the two nurse check matters so much. This is what we are trying to prevent. And circulatory overload. The patient gets too much fluid too fast. Their heart cannot keep up. What is happening? Blood is a fluid. If we give too much, especially to older patients or patients with heart failure or kidney problems, the extra volume overloads the heart. Fluids backs up in the lung. Sound familiar? Heart failure? What you see, shortness of breath, cough, crackles in the lungs when you listen, swelling, distended neck veins, maybe pink frothy sputum, anxiety. You stop or slow the transfusion, sit the patient up to make breathing easier, notify the RN. The team also often gives a diuretic like Lasix or furosemide to help the patient pee off the extra fluid. Sometimes oxygen is needed. Circulatory overload is more common in elderly patients and patients who already have heart problems. So for those patients, we give blood slowly and watch closely. So the bottom line is stop the infusion if you notice a reaction occurring. Stay with the patient, call for help, maintain IV access with normal saline through new tubing, save the blood bag and tubing for the lab, monitor the vital signs, document everything. Okay? After the transfusion, if the transfusion goes well with no reaction, you finish the unit, you flush the line with normal saline, you take a final set of vital signs, and you document the completion of the transfusion. The patient continues to be monitored for delayed reactions for several hours. If you stop because of a reaction, the lab analyzes the bag, the team treats the patient, and the team documents everything that happened. There also may be a transfusion reaction report filed by the hospital.